Hi, everybody. Can you all hear me?
Yeah, I can hear you, Chen.
Yes.
Okay. So thanks for joining in there. It's good to see so many of you online. There are a couple of us here. I did say in the beginning that we won't have any slides, but I find it very hard to not have some slides. So there are going to be a few slides that just form a framework for our discussion. But the aim of this is more a roundtable discussion around some of the common safety issues and complications that we might expect to see in regional anesthesia. So I'm just going to start this by sharing the screen. And as you know, I did share some articles that I hope our fellows have read. And for those of you who are interested in, I hope you got the links. I think they're very useful summaries of the four main issues that we're going to be discussing today. So while I've said to some of the fellows that feel free to bring up cases that you've encountered and use those as a stimulus to discussion, I certainly don't share any specific identifying patient details if you do bring up any of your personal experiences, because obviously this is not a confidential or private session. So the first thing that I thought would be nice to talk about is the whole issue of telling our patients about risk and consent. And in a recent supplement to Anesthesia in 2021, one of the articles in there was about this process of taking risk and what it means to consent a patient, especially when it comes to regards to regional anesthesia. And there's some good points that come out of that, which you'll see I've listed on the side as well. I think we all know that it's sometimes challenging to make sure that patients understand really what is being offered. One thing is always, how do you quantify risk of complications to patients without scaring them unnecessarily, and yet also not necessarily communicating your own bias for one technique over the other. The other one that we all face in training institutions is what it means to allow a trainee or a learner to perform the procedure. And one of the things that's brought up here is to emphasize that although there is a duty to make sure that we're training people, at the same time we want to make sure that we minimize risk to the patient. But the authors of this article, which do include somebody who often represents medical legal cases, emphasize that patients do have a right to know who is actually doing what to them, and also if they ask, how much experience that particular practitioner has. So those are sometimes a little bit of thorny issues for us to deal with. At this point, I'd like to have a little bit more of a discussion, particularly from the trainees. Have you found the issue of consenting patients difficult, and in what aspect of it? And feel free to unmute yourself and speak up if you like. But maybe Pear, you can start.
Okay, so for me, the most difficult part for me is the one that with the language barriers, say that he or she didn't understand English at all, and sometimes it's hard to find interpreters, especially if the interpreter is on the phone, because we have to give like them and the phone. I mean, the voice on the phone, I'm not so sure if it's clearly enough. So I have to admit that I have problems here, that everyone says that so we got like a little bit wrong, because so I'm not sure at all if she understands what I'm about to do. So we're gonna do the pen block because he has the hip pain, the hip fractures. And so I asked him, so it's the hip fractures, right? We are going to do the injections around the hip to make you more comfortable on the lateral positioning for doing the spinal. So after we do the hip, the peng block, and we turn the patient on the side, it seems that he didn't has very few pain at all. So the problem is he didn't have the hip fractures. He has the fractures on the upper femurs.
Right.
So it's actually my fault as well that I didn't pay attention a lot at the time of the time out. And yeah, because I think I asked him already. He can speak English, but probably not that very well.
So actually, that's a slightly different scenario. What you're saying is that you didn't understand the surgical condition correctly, and you did a block that was less appropriate.
Yes.
Right.
But
Right.
there's also another.
That is a problem with communication. I think that's a separate issue you brought up, which is that so-called hip fractures are a hip fracture is a very non-specific term, right? Because what is a hip, right? It can be anything from the acetabulum to the femoral head to the femoral neck to the trochanteric area to the subtrochanteric area, maybe even proximal femurs, people might call a hip fracture. And it is a good reminder that we need to understand that as much as we can the patient's surgical condition as well as all the medical conditions, and especially in regional anesthesia, right, when we're choosing a technique, and so that we can apply the appropriate technique. All right, but I do agree with you that communication, particularly in somewhere like Toronto, where we have lots of different languages, is going to be an issue. And I think we're sometimes forced to be quite simplistic with our risk discussion.
Yes.
One thing that comes up is when we talk about magnitude of risk, do we quote numbers or do we not? Too bad I can't run polls, but I'd be interested to know who are believers in quoting actual numbers and who are those who like to talk in terms of uncommon or rare or minimal.
I do talk as rare because it's easier for us to understand. But yeah, it's my type of doing.
What do you think, Angie? Do you personally quote numbers?
I personally, I'm just going to sit a little closer.
Sure.
So personally, I don't quote numbers unless the patient asks me. So I tend to say this is a very safe procedure. I usually preamble it that way. This is a very safe procedure and the risk of complications are quite rare. They're not zero. So things like bleeding, infection, nerve injury are all possible, but they're all quite rare. And on occasion, I've had patients that ask me, what do you mean by rare or how rare? Then I quote the numbers if they ask me that.
I do see Arun has mentioned in the chat that he quotes numbers. How do you express those numbers, Arun? Do you use percentages or do you say frequencies? I'm not sure if Arun will mute. So one of the things that this actual article that I referenced to you, they do actually recommend that we use numbers because they say everybody's interpretation too of uncommon or rare is different. But they also make the point that sometimes percentages don't mean very much to people. They recommend that we talk in terms of 1 in 1,000 or 1 in 10,000, and they think that people can appreciate that better. Although I think even that is open to debate as to what that means. Karen,
Can I just actually make a comment as well? I was recently speaking with a colleague who historically had an issue and then had to consult CMPA, and I never like practicing with CMPA in mind. but it was interesting to have this conversation with him. And this was like 10 or 15 years ago. But he said at the time, CMPA actually told him that he should be using numbers and he should be documenting numbers because that is what their recommendation was. And I haven't actually called them to follow up or had a discussion about this, but it just gave me pause to think that this was historically the recommendation. I don't know what the recommendation would be now, but they obviously said it for a reason. So I don't know, I guess I bring it up that just even thinking about liability and legality and documentation of all of that, like maybe we need to be doing a different job, a better job. I don't know.
Mhm. So that's interesting, and like I said, it's actually also reiterated in that particular article. And the reason they give is that it's a bit more of a concrete fact. I'm not wholly convinced that patients necessarily understand it better, but perhaps it's something that is, firmer for us to stand on. But
I also think the challenge is sometimes then when you're weighing the risk benefit of like a general anesthetic, like I know in one of the articles it talks about this, but it's like the complexity of patients. Like it's you giving the anesthetic, it's the patient, it's then the choices of these things, it's the surgeon. Like there's so many other layers that go into this conversation that there's no way you could document all of that or even like really like distill all of that to the patient.
that's true. We also have this issue of we could have a long detailed discussion, but capturing that on paper so that there is no dispute about what was said, I think is also a challenge.
And can I just add, also it depends on the patient, right? Now, some patients would like to know exact details as to the numbers and the incidence, or whereas some others are a little more receptive of the fact that they are okay with trusting you in making the best judgment. So I don't scare everybody with quoting numbers and specifics, but you really have to go by how the patient is receiving your initial pitch for the regional, and then and how eager they are in terms of knowing, and I then deliver more detail and then I document as required.
Sorry, I had a quick question regarding this point too. Sorry, I'm not in the regional group. I hope it's okay. I asked.
Everybody's welcome here.
Yeah, so same with the point, like what happens if you had patients, sometimes you put epidural in and it says, well, here's the risk. It's like, I don't want to hear it, don't tell me, just do whatever you think is right. In that case, do you still push to be like, well, there is still very rare, like I think those patients, you don't want to tell them numbers because obviously that's already, they're already scared or whatever. But would you still go, here's, there's a very low chance of, infection and nerve injury, because I think, or do you just like in terms of documentation, what do you like, there's a normal spiel and then there is these patients who says, don't tell me, or tell my husband or something like that. Like, how would you approach these kind of situations?
Anybody out there have some thoughts? Well, go ahead. No,
I just want to say, it's important that the one in the driver's seat here is the patient. So if the patient tells you, I don't want to hear anything about the risks, but I'm okay having the procedure, obviously, I think it's reasonable not to force the patient to hear the risks if they don't want to hear it, but you can document it as such. You can say, I had a consent discussion with the patient declined to hear about the risks, and something like alternatives discussed or something like that. And then, you're definitely covering yourself. Again, what the law of consent to treatment in Canada says is that you need to discuss with the patient the material and special risks of the procedure and alternatives. That's what you need to discuss. And so, if the patient doesn't want to hear part of it, but they are happy consenting to the procedure, then I think it's acceptable because it's ultimately their choice. That's my own personal take on this. What do you guys do? Do you tell them
Evan,
anyway?
Well, what did you do, Evan? I presume this actually happened to you.
I basically said, there are still some risks, but I think it's beneficial for you as the patient, and we will proceed with that. And I kind of, I didn't, in this case, I just kind of said there are risks and just left it at that, because I think the patient was really anxious to begin with. And I mean, as you said, I documented it, but again, I never phoned CMPA. I mean, everything went fine, but I just don't know if something did bad happens, like what would, again, as someone has said, that I wouldn't want to practice just because of CMPA, but I think this is also kind of important, and I just was wondering what other people did.
Well, my personal take is, you document as and he said that you certainly attempted to involve the patient in a discussion about risks and consent, but the patient declined the in-depth discussion and otherwise agreed to have the procedure done, following an explanation of the procedure. And I think then, I suspect it wouldn't go anywhere if that was documented, because you did make the effort and the patient didn't want to hear it. And ultimately, I think we do have to do what we think is in the patient's best interests, or at least present that, right? Because as Sharon and you quite correctly pointed out, it's complicated, right? The whole risk benefit and the risks of the alternatives, which we mustn't forget. Although those of us who love regional have to be careful that our biases don't creep in, and that we overestimate the benefits and overplay the risks of the alternatives. But we kind of have the fuller picture, and so I think we kind of have a duty to interpret that for the patient. But just for,
thank you very much.
Yeah, so if we did want to probe frequencies, let's say peripheral nerve blocks, what would you say? So we have another one of our trainees, Jeanette, has joined us, so I'm going to put her on the spot. What would you say to a patient who wanted to know what the risk of a nerve injury was with a peripheral nerve block?
Well, after reading one of your papers, you're saying 1 in 1,000. Yeah, 1 in 1,000 is 0.1%.
Would you qualify that at all?
And 15% of those patients had most of those improved. So this was what you want to know is, like, if you do have a nerve injury, is this something that's going to be like how long standing is it? So the vast majority of them will improve after 10 days or so, and the rest of them usually within a couple of months. But about 15% of the nerve injuries will have longer standing ones that will last for a couple of months or years.
How would you say that to a patient?
Well, I never really thought about it. I thought it was interesting. One of
Yeah.
the papers they talked about, like, don't quote numbers. And
They-
I couldn't believe it. One of the papers you were saying 20% of Americans with university degrees
Mhm.
didn't know if there was a greater risk for 5, 10, or 20%.
Yeah.
I thought that was very interesting. So they thought that you should talk about it. So for every 1,000 patients that have a nerve block, 1 patient is going to have a nerve injury. Apparently patients take that in a bit more.
And that's what it says in the McComb and Bogart paper, is that they say you should talk in terms of frequencies. So like 1 in 100, 1 in 1,000. That's their recommendation. Yeah, because percentages people have trouble with.
Yeah.
But
and then I suppose so less than 1 in 1,000, less than every patient in 1,000. So what would it be? Like 1 patient in 1,000 is going to have a long-lasting. So 1 patient in 100,000 is going to have a long-lasting nerve injury from a nerve block.
Yeah.
1 in 10,000.
I'm just gonna. We're segueing a little bit into the second bit, which is really the instance of neurological complications. And we did publish, one of our fellows, Karen Lam, did publish a retrospective cohort study from our data here at the Toronto Western Hospital. And this is what Sinead was alluding to, that we looked at our records from 2011, 2017, and identified 20 patients who had had some sort of neurological injury. The good news was that of those, only 3 were likely related to the block itself after extensive investigation. One was very interesting and something that's really rare, I think, which was a phrenic nerve palsy after an interscaling block, an acute one, which is very unusual. Luckily, the patient recovered. It is not clear to this day how that actually got injured, because it was a lateral to medial approach from my recollection. There was a femoral nerve block injury from a femoral with a femoral neuropathy, and a popliteal sciatic neuropathy from a popliteal block. And I do believe I've heard of a couple of other ones since then. So the popliteal sciatic does seem, because we do approach quite close to the nerve, is one of those that's possibly at a little bit more risk. At the same time, you'll see that a significant proportion have nothing to do with us at all. And I think that's important to remember. We tend to get the blame, obviously, but a lot of the times there are going to be causes from intraoperative things. So particularly the orthopedic surgeries, it's important to be aware which operations carry risks. Tends to be a lot of the arthroplasties. Obviously, if they're doing nerve decompression type surgeries, you could get caught in that. It's interesting that we do surgery for ulnar decompressions and we do brachial plexus blocks and all that thing, because some people talk about a double hit and the double crush phenomenon, where anesthetizing a nerve that is already compromised, does that increase the risk that that nerve will be further damaged? But I will say that based on our history, there has never been an issue. So we continue to do that. But some people might be more conservative. You'll see here that particularly in the lower limb, tourniquets are an issue. And the lateral femorocutaneous nerve from positioning, especially during lithotomy. And certainly I'm aware of a couple where the straps that they often put across the thigh, if they tighten that too tightly, especially if they put them in a sitting position, all that kind of thing can bite and compress into the nerve. So it's something I want to be aware of. Then obviously casts and things like that. But I think the other thing that I would say is that when you talk about nerve injury to a patient, it is important to characterize that a little bit more, right? Because nerve injury is very scary as a term, but as you said, the important thing is how transient is it versus permanent, and also, what's the manifestation, right? Mild tingling, little bit of altered sensation, complete loss of sensation, neuropathic pain, or motor deficits, right? And they all can have very differing impacts on patients, but the duration is something to think about. And so I think, certainly myself, actually, if you look at the data, transient neurological symptoms are really very common, right? And those of you that have been making follow-up phone calls, what would you say about the tingling that people get in their fingertips the day after a brachial plexus block? Do you find it being reported commonly?
Yeah.
Yeah.
I'd say most days you get one patient or two. But most days one patient, if you ring 15 of them, you'll have to follow them up the next day.
Yeah.
In that paper, it was 14%.
Yeah. And so actually, now, I personally nowadays almost always tell patients, I think my phraseology is, it's not unusual that you will feel temporary numbness and tingling in your fingertips for up to a day afterwards, but don't worry, it will go away. Because yeah, the data is definitely in the multiple percentages. So 1, 10 in 100 even. So I think it's always worth reassuring patients that that's to be expected. But as you say, the data for more prolonged injury, I would say, is much less common, right? And that's where you can quote the sort of 1 in 1,000 for changes that last longer than 7 to 10 days. And then permanent damage, I tend to go with the very rare phraseology rather than put a number on that. What about our other expert faculty? Do you have any opinions to share with us?
I often do like I tell them not the like I say it's relatively rare, and I usually use the 1 in 10,000 as a number, just based it, and it seems to be consistent with what you presented. But just kind of mixing with the last comment too, it's hard sometimes for patients to actually appreciate what that means. Because then I've had some say, well, like, what does that exactly mean? Because you can give them a number of 1 in 10,000, but it's hard to really inherently understand what that actual risk is. And I think part of what I do sometimes is like, I realize that a peripheral nerve block rarely is going to really save the day in most of these surgeries. It usually helps with your anesthetic. If you have to go for a GA, you can be lighter with your anesthetic management, and it helps in the postoperative period. I think where the conversation I have more of a real conversation with patients is often when I'm trying to, I don't want to say convince them, but where the neuroaxial technique is really going to have a significant impact on their perioperative care. And sometimes, and I don't know if everyone else said this, but this is what I do, and maybe we can even have everyone critique me for what I do, is that I actually give an honest opinion of what I think would be in their best interest. And I often use the line, you know, if you were my family member, this is what I would recommend. And I kind of leave it at that, because I think that's a really powerful statement. And then usually it allows for more discussion. And I'm pretty soon to see right afterwards if the patient is already so apprehensive, there's no way that we're gonna, I don't want to say convince them, but there's no way that I can kind of sway them into why these are more beneficial. But I find that that's often a good phrase for them to kind of have a little bit more buy-in when I'm talking to them.
Has anybody here ever had a patient change their mind and refuse the block because of that risk of nerve injury?
I've had them refuse blocks, but they've usually, they've gone into the conversation being very apprehensive, and then it's just reinforced when you start talking about complications.
Mm-hmm.
I've had the opposite happen, where I've had a patient, that patient accept a block, often though because the surgeons recommend it, which is interesting, but it talks about the team approach. I'm okay with it. I'm like, if everyone's on board, sure, whatever.
Yeah, it's quite funny, right? Because if you really want a patient to agree to block, you say, you know what, that's what Dr. X likes to have for his patients. I'm not sure that's a good part of the consent process, but obviously it starts to get a little bit more complicated if you believe that the risk is increased, right? So a good example, and I think one that comes up fairly commonly, is spinal anesthesia in somebody who's got known spinal stenosis. There, you know, there is some data that the risk of worsening a pre-existing sciatica is present, particularly if you do epidurals. And then the other one is people who have pre-existing neurological disease. The common one that often is brought up is diabetic neuropathy. Anybody have thoughts on that? Do you do anything different for people who've got diabetic neuropathy? Oh, Sharon, were you going to say something?
Yeah, my only two persistent neurological, when I did phone calls and follow-up, were both on diabetic patients. Actually, and one was on a Charcot-Marie-Tooth, but that was a bit more complicated. But the two that kind of stick in my mind were diabetic. So I'm often very cognizant now. You have some guests, we have some guest speakers, cognizant when I have diabetic patients for this reason, because I think we underestimate. Sheila Riazi actually published something as well. She had an article a number of years ago, and I think we actually, you know, we see it so routinely. It's kind of like one of the common diseases, and maybe we underappreciate the potential risk to patients. And then compound that with the multiple hit, which includes tourniquet and surgical, and I think these patients are at high risk.
Did your patients though eventually recover?
Yes, all three of them did, but I called them probably for like a month afterwards, like not every day, but inconsistently. Yeah.
So as you can see from our series, we haven't had any that were related directly to a diabetic neuropathy, but it certainly comes up in the literature a lot that we should be careful with patients who have diabetic neuropathy. Some people even suggest using more dilute concentrations of local anesthetic, arguing that because they have nerves that are more sensitive, that you don't need so much anyway. I gotta admit, I'm not sure that I consciously do anything different in terms of the block. Do you?
I don't do anything particularly different. And again, just the years of practice that we've had so far, I don't recall, and in this series that we published, we haven't had any particular patient that posed a diagnostic dilemma or something like that afterwards. Is this related to the diabetes, or is this related to the block or the surgery? So I personally don't change it very much, and the incidence of diabetes, of course, in our patient population is quite high. I would say in the order of 20% or so at least. So we would be changing, our practice for a lot of patients. And I'm not saying it's right or wrong. I personally don't do it, but I think it's reasonable if someone wants to, alter maybe the risk benefit ratio a little bit more away from the block. If you're in doubt, I can see can be a reasonable thing to do.
Having said that, I think we reduced the concentration of epinephrine we use for a few years now, right? We've gone down to 1 in 400,000, keeping this as one of our potential risks to reduce the risk of any further deterioration in the neuropathy.
Right.
Yes, we've done that for quite a long time. 1 in 400,000 because of the possibility of constricting the vasa nivorum, which in some early studies was implicated and certainly shown perhaps in animal data. I can't remember exactly. I think, though, my impression from the overall data is that when it comes to, I always, one of the things I say to the trainees is that there are two things I think that are within our control. One is mechanical trauma with the needle. And then the second one is the chemoneurotoxicity, depending on how much, what agent and how much of it you choose to inject around nerves. We all know that local anesthetics are neurotoxic. And there's some argument for using the least possible dose that you need to ensure success. But I do think that most neurotoxicity that results from the local anesthetic, as long as it's in the right place, which is outside the epineurium, is always going to probably recover. I think it's very hard to cause permanent damage with local anesthetic, although there may be a transient worsening of things. Usually there's some other risk factor that has contributed to the more permanent damage, and probably an element of mechanical trauma. You wonder sometimes if you puncture a nerve and then you inject around it, and thus more local anesthetic penetrates that nerve, then perhaps you're exacerbating things. So I'm certainly not a believer in intraneural injections, although I think there's still a small proportion of the world out there that would advocate it.
I think I happened to have to review this topic a couple years ago for a lecture in ASRA, and looking at all the animal studies, I'm very convinced that the cases of nerve injury from regional anesthesia, the majority are more from neurotoxicity than from the needle itself. But the neurotoxicity happens, as Ki-Jinn was saying, when you actually inject intraneurally. There's lots of animal studies that I think it's quite consistent that show that when you inject local anesthetic around nerves, it's exceedingly safe. So the degree of cell death or neurotoxicity, it's not zero, but it's almost inexistent. But if you inject exactly the same local anesthetic inside a nerve, it's quite clearly proportional to the amount that you inject, to the concentration that you inject. And there's also lots of animal studies that show purposefully putting needles into nerves don't cause a lot of traumatic mechanical injury. So it seems to be, again, it seems to be that in putting the needle into the nerve and injecting local anesthetic, that's what's really damaging to nerves, based on animal studies anyway.
There are two more points that I'd like to bring up before we leave neurological injury. One is a cautionary tale. So our chief here, Atul Prabhu, has recently gone around to tell us all to make sure that when we clean the back with chlorhexidine, to make sure that it's fully dry before you insert any needles through that skin, because apparently he has been consulted on a couple of cases where there have been neurological deficits following neuraxial blockade, and it's implied that they were inserting needles through chlorhexidine that hadn't dried on the skin, and perhaps carried some of that chlorhexidine into the vertebral canal. And it's quite well known now that chlorhexidine is quite profoundly neurotoxic. There's a celebrated case in the UK where a large amount was injected, of chlorhexidine was injected accidentally in place of local anesthetic. But it appears that perhaps even if you carry a little bit in towards nerves, it's probably not a good thing. So that's just something to bear in mind. I think most of us, by the time we've prepped and got our stuff ready, that chlorhexidine will have dried, but it's something to just bear in mind. The second one is TNS, transient neurological symptoms. And I think it's becoming more of an issue because certainly we are doing more and more day surgery spinals, and it is certainly in North America, the only thing we really have is mepivacaine or lidocaine, both of which are associated with an instance of TNS that you don't see with bupivacaine. Are you guys talking with patients? Do you mention that as a specific risk to patients?
I haven't found a way. Sorry, I do try to mention it, but to be honest, I find it really hard, difficult. But I just like, I think if someone, I don't know how you put that into words, because I don't know how, if someone told me that there's a chance with an mepivacaine spinal that you're going to have 10 days of pain, and it's not an unreasonable, there's not an unreasonable risk of it happening, then I think I would say, well, no, I want general anesthetic. So I do briefly mention it, but I probably don't go into as much detail about it as I should. And a lot of that is because I just don't think the patient would accept a spinal.
I'm going to put my hand up and say I don't mention it. Although I've been beginning to wonder if I should, but maybe it's easier to ask who does routinely tell patients about TNS if they inject mepivacaine. Is there anybody?
No, either. Having said that, I've had one classic case of TNS following mepivacaine, and I just assume the so-called nerve injury disclosure kind of includes this, but I don't scare them with that TNS symptom though.
Have you guys actually been seeing, so I know that we're all doing more ambulatory surgeries and we're all using mepivacaine or lidocaine more frequently in our sites. Have you guys actually seen, like, personally, or is this just more the theoretical stuff? Because I know, Jen, you said, oh, we're seeing more of the TNS symptoms, but I mean, we've been following up on patients and none of them complain. I never consent them for this or disclose this because, again, I don't know, I kind of think in my head it's under the umbrella, but we haven't had patients tell us either.
So until very recently, I would have agreed with you, right? Because we don't, the number of severe TNSs where patients are like saying, I have this really severe pain, and we need to keep following them up. I believe we can count on the fingers of one hand over the last several years. But I recently was talking to one patient that I followed up, and I can't remember how he got onto it, but I think I was just exploring how his legs had felt after this, and he said, "Oh yeah, I have this, my butt kind of like aches." But he almost did it like a throwaway comment. He was always very chirpy and happy. He was driving around actually that the next day. But so I think that there may be mild versions of it that they don't necessarily attribute to our spinal, but maybe it's like radiating pain up, it's like muscle ache or whatever that they. So I guess I'm going to say that it may depend on how we define it, but I probably agree that the severe symptoms are low. But Sheena, you bring up a good point, right? Which is you kind of want to have to think about how you're going to say these things so that you're not scaring people, because it's not like we're going to stop doing the pivocaine spinals for day surgery, because there are certain demands that require us to use that make pivocaine not acceptable. So yeah, it's a bit of a tricky one. But I do think that because we know from all the data that it's transient, you could have a case for not discussing it.
It's on our consent form. That's the reason I think about it.
It's on the EPIC one, is it?
No,
Is it on ours as well?
It's on one of the
Not on
consent
our,
forms. Maybe
it's not
the EPIC one.
explicitly on our paper one.
It's not.
Maybe it's the EPIC one. Oh, it's the EPIC, yes, the new consent form is.
Yeah, EPIC.
Yes, they have it. So that's the only reason I thought, oh, I should really start talking about it more.
So that's one of the reasons I don't disclose TNS specifically, because it is a transient one. It's not a permanent one, serious enough to be told specifically about. So that's my reasoning behind not disclosing. Patient I've had in the last 10 years had such a classic symptom. She developed pain just after leaving the hospital, and that lasted for a week before it got better. Quite disabling, but it eventually got better after a week.
I just want to say that from my reading that this transient TNS is always there, never disappeared, and it actually can happen with any type of local anesthetic. It's not that we don't see in bupivacaine. The reason is being that historically there are higher incidence with lidocaine when they're using 5% lidocaine for the subarachnoid blocks. And they found that with the lower concentration of local anesthetic that we use or spinal, like for example, using bupivacaine 0.5%, the incidence has gone much lower. And basically anything below 1%, you hardly see the incidence of the TNS. But when you go higher, like you're using lidocaine 1% or even 2%, you just see that you probably see more of the TNS. So probably that's the reason that we seldom see the TNS nowadays, because you're using bupivacaine and some places use ropivacaine. And I think with in ambulatory surgery that we were using lidocaine more and more, it tends to see this condition more and more again.
Thanks, Yumin. A couple of points come up from there. Actually, lidocaine, yeah. So the bad rap of lidocaine comes from the use of 5% hyperbaric, particularly in the old days. But there are lots of places now who have returned to lidocaine 2% as basically mepivacaine 2% and are using that without much incidence. I do agree personally that the issue of concentration is probably one factor. I personally like to dilute my mepivacaine to 1.5% in the hopes that I might reduce that risk. I'm not aware of the good data otherwise, but what I do know is 1.5% works well enough, so I tend to do that. Yeah. But I guess it may be one of those things, if you start to see a lot of it, it may turn out to be something that we need to tell patients. But it's similar to say urinary retention, right? I'm not sure that we discussed that as a adverse effect of spinal, especially when discussing the options. But it is something that's potentially impactful if they need to have an in-out catheterization or delayed discharge. So I think much as we talk about complete disclosure of risks and adverse events, I think we unfortunately, when it comes to neuraxial stuff, I think we are guilty of being a little bit selective, right?
Mm-hmm. just as an addendum, and again, you know, there's care implications for the patients, and there's the medical legal side. And I agree, it shouldn't be top of our minds, the medical legal side, but you know, we should keep it in the back of our minds and certainly practice according to what is recommended medical legally. And I know in our conversations with CMPA in the past, when we had panels and things a lot years ago, they suggested quite clearly that if you tell the patient about a serious side effect and you document that, and they end up having a more minor side effect, usually that's not a problem medical legally, because the judges and it will never get anywhere. Basically, you won't even get to trial, because they will say that any reasonable person that accepted a serious risk, they would accept a more minor risk if that is the case. So I think but the opposite doesn't work. So if you only tell the patient about a transient headache, that's it, and you forgot to mention that they could have a nerve injury, for example. I think for most people, having a nerve injury would be a more serious side effect. So I think it's important to mention the more serious complication. You can make it short, you know, you can put it in context, but I think it is important to mention the more serious complication, and you can forget about the more minor ones. It's a lesser problem.
And I think it's a good place at this point to talk about what you actually do when this happens. And you know, a lot of times, just because a complication happen doesn't mean you're going to land up in court over it. And it's pretty well established that how you treat your patient and communicate with your patient determines whether or not they're going to take it all the way to the lawyer. All right. So obviously there are some patients, you know, your antennae may go up when you're talking to them and they seem a bit strange, and you might want to be more conservative with them. But otherwise, a lot of times people are quite understanding of these things that happen. And you know, I think as long as you afterwards when you manage it, you are appropriately reassuring and go out of your way to make sure that you are there to make sure that the patient comes to no harm. All right. And thinking about what to do about these things, a lot of times you're going to, especially the sensory, there really is nothing to do, and you're going to have to be conservative in your management, reassure them, follow them up. You want to be aware though that if you want to prevent them from secondary harm, right? So if they have a very insensate area, you should protect them from pressure injuries or thermal injuries. If they have motor, if there is nothing else to do, like you can't do a surgical repair, things you need to look after contractures and stuff like that. Neuropathic pain, and our chronic pain colleagues who are on the call can speak to this, but neuropathic pain is the other thing that can sometimes arise. So I think if they're having symptoms that are suggestive, so it's not just some mild tingling or mild numbness, but they've actually got pain, it may be reasonable to start a neuropathic agent. And certainly I have enlisted the help of our chronic pain colleagues in doing that and providing some additional follow-up. And again, remember that sometimes this is not going to be your fault, especially foot and ankle. I will tell you is, our chronic pain colleagues here will tell us they get lots of patients coming post foot and ankle surgery in their clinic who have all sorts of neuropathic pain or CRPS that is a result of the surgical trauma, nothing to do with the needle. We're often involved because people naturally refer them to us. And at that point, etiology is not really the most important thing. And it's one of the things I do tell patients that this could be the causes, but the most important thing is what we can do to make it better and while we wait for it to improve. And so keeping that in mind and treating it with neuropathic agents, with reassurance, with physiotherapy and all the other things, all the multidisciplinary things that our chronic pain colleagues can help us with is very important.
I have a question, Ki-Jinn.
Yes.
After time do you start to treat the neuropathic pain? Because when it happened, sometimes it takes some time to realize that it's a chronic one, and you need to kind of consult the chronic pain doctor. Do you start right away if you have a patient with numbness at the end of regional anesthesia? After 2-3 days, you already start to give him some gabapentin, or you wait a little bit more time to start giving him the therapy?
I'll offer my thoughts, but then I'd appreciate it if some of the chronic pain guys will chime in. But I personally will ask myself, if it's just mild numbness, then usually we do nothing. If it persists, I usually would, and it usually is quite profound, or they have shooting pains or lightning bolts, or there's an element of discomfort associated with that loss. What I will do is bring them in, all right? Because once you think things are more serious than just that transient sensory loss, what you really need to start doing is documenting, okay? And so what we often do is we'll ask the patients to come in, and we'll then start to look for other features that are classic of CRPS, right? Like skin changes, skin color changes, and characterize that deficit, the pain. And I don't know, my bias is to say the ones that I've seen or heard of, we have started a neuropathic agent sooner rather than later. But Sumin or Carrie, would you like to, or would you like to comment? Is there a good
Yeah, I think I kind of like agree with Ki-Jinn that it depends on the symptoms of the patient. If they doesn't have, sometimes they just have numbness, and numbness might bother them a little bit, but not causing too much of discomfort. I wouldn't start anything. It's just sensory components. But sometimes they have numbness with severe pain, then they are like in moderate to severe pain. I think one of the reasons why that pain can progress is that when you don't treat the acute pain, this is considered kind of like acute neuropathic pain, because sometimes we are not sure whether it will become chronic or not, because you need the duration of 3 months to diagnose it as a chronic pain. As well as CRPS, it also takes 3 months. So this kind of the timing or duration of the acute neuropathic pain, the treatment can be crucial. That if it's a severe, moderate, severe pain, then preferably we'll start some neuropathic agents like pregabalin, gabapentin, that if you control the acute pain phase well, it kind of like reduce the risk. I wouldn't say it prevent it to go to CRPS, but it kind of like reduce the risk.
And obviously, this kind of therapy needs to be sort of gradually escalated and followed up over a period of time, right?
Yeah, definitely. We usually titrate the medications up to probably a reasonable level, and then we just watch how the patient responds to the medications. So yeah, we usually follow them up, and you can actually bring down the medication if the symptoms are better.
And I think that's an important thing, is to realize that it might be difficult for us as just pure anesthesiologists to manage this. And so, you know, having the ability to refer to one of our chronic pain colleagues is, for me, very, very reassuring, because somebody has to do that longitudinal follow-up. And if they're not available, you have to ask yourself who could do it, right? And that's a problem to be solved as and when.
Thank you.
Can I add one other point to this? So I've had 2 patients have persistent neurological injury that I didn't do blocks on. One was actually a massive postpartum hemorrhage, and she used her hands to work, and we had to put like lines in an emergency situation. And then she had some median nerve persistent problems. And another was a pregnant patient who was coming for non-pregnancy surgery, and we gave her a spinal, and then she had like lumbosacral plexus pathology where she couldn't even move her leg for like days. And the comment I just want to make in terms of like referrals as well was, in both of these cases, we had neurology involved pretty quickly, because we needed EMG studies and we needed NMS studies just to be able to, one, see what the actual underlying like pathology was, but also in terms of like assessment, management, documentation. So I think when you're starting to think about all these other agents as well, I think that sooner is better than later, because you just really want to start documenting from time 0, and then being able to track progression from that point onward. And I think that's it, like that objective measurement is a key piece that you just need to, like, maybe this needs a neurology consult, maybe this needs more objective testing.
Thanks, Sharon. I think we all agree, and I've just put up this slide. It's part of that article. We include the pathway that we have at Toronto Western, which does include a referral to a neurologist for certain indications. And we, again, are lucky, those of us that work in the tertiary institution, to have ready access to neurologists who are willing to see these patients and assess them and do early nerve conduction studies. So it is an important part of it. Thank you. Okay, it's getting on 6 o'clock. There are a couple more things I was going to talk about. One is that perennial question of anticoagulation and regional anesthesia. Won't spend too much time here. We're all aware of the different guidelines, and particularly with regards to neuraxial block. It's a little bit more of a thorny question with the peripheral nerve blocks, I think, where you have to, you may not want to be applying a stringent criteria. Your threshold may be a little bit different. And I put up the second article, which I didn't send around, that was published in the CJA. It was led by Ban Sui, who is out of Edmonton, although now he works in Stanford. But he basically gathered a bunch of us so-called experts from around Canada, and we kind of got together to make a certain judgment about the bleeding risk associated with various blocks. But what I want to highlight to you is what he calls the CIA model when trying to decide what the risk of bleeding, and specifically the risk of any complications related to bleeding, might be. And so CIA stands for critical, I is intervention, and A is assess. And what it means is that the critical is where you're puncturing, and if any hematoma is going to develop, is it close to or remote from any critical structure, right? And so any structure that might be compressed by a hematoma, or any large vessel that is at risk, I guess, of puncture by your needle. Intervention, when you did puncture a vessel, can you compress it? And the example I always give here is the old transarterial approach to axillary. We thought nothing in those days of puncturing an artery, making 2 holes at least in it, because we could compress it, and it was completely fine. So if you can compress it, even if the patient's mildly coagulopathic, you might still choose to do a superficial block because it's inconsequential. You can stop any bleeding. And then the third one is if you did puncture too, you want to be able to monitor the patient so that you can tell that they're not bleeding out, or that they're not having a expanding hematoma that would need intervention. So I certainly use those 3 characteristics in trying to make that judgment about whether I should do a peripheral block in somebody who doesn't have completely normal coagulation, and take that into the sort of risk-benefit analysis. The other thing I brought up, and I encourage you, if you haven't read this other paper, which is the one from the BJ Education, is because they reference a recent advisory by the Association of Anesthetists on hip fracture patients, where they're suggesting more lax standards for spinals in patients who are on anticoagulants, where they believe that spinal anesthesia is inherently safer than the general anesthetics. And they actually suggest that it is okay to do spinal anesthesia on patients who are receiving single antiplatelet agents, which would mean that you can do it on patients who are on just Plavix alone, or the equivalent antiplatelets. Dual, they probably say that you should still stop. But when it comes to the direct oral anticoagulants, that same guideline starts to suggest that anything more than 2 half-lives, which is then 24 hours of the last dose, is also acceptable if you believe that spinals carry a much greater safety margin over a general anesthetic. So it's quite interesting because you have an organization that's going out on a bit of a limb against what most of us accept in terms of the ASRA guidelines. So it's something to think about.
Ki-Jinn, can I make a comment?
Yes, please, Josh.
So really interesting, that CIA approach. I think it's very relevant and useful. The one thing I would add is the benefit. because it's almost like the way FDA approves drugs, right? Like they'll still approve a drug like TPA because the benefit obviously outweighs risk in the right context. So I think also the same with nerve blocks in the context of anticoagulation. If it's like some patients with severe chronic pain, you may be more comfortable with increased risk versus a patient who you feel you'd have a very easy time controlling their pain with multimodal analgesia that's not a peripheral nerve block. So I think that's another thing to consider. I have a question, and this is very relevant to what you mentioned with the spinal. So I just had a hip fracture last week, 48 hours off Plavix. And as they wheel her in, the hospital calls me, tells me they diagnosed her for pneumonia an hour before. And she did not look well to me. She was on nasal prongs. She was febrile throughout the day. And you know what you mentioned about that idea, like the recent commentary about extending with spinal on a single platelet agent, which she was just on Plavix. I was really torn and actually ended up calling like kind of a friend for help who was upstairs on call to see what they would do. I ended up actually delaying the surgery because I was also worried to see what trajectory her pneumonia is heading. But I think these are tough choices. And like, I don't know if I made the right choice. In the end, she had the surgery 2 days later under general anesthetic. Her pneumonia didn't deteriorate further. She was still on nasal prongs. But I think in these situations when you're kind of in a gray area, it's always good to call a friend, have colleagues that you can depend on and see what they would do. And just at the end of the day, just document things as best as you can.
Yeah, you know, I completely feel for you there, because I think one of the difficult things is actually, I think we actually don't do a very good job of estimating the risks of general anesthesia. I think personally, a lot of times, some of these respiratory issues, I do think that we overemphasize the impact of that. I mean, you know, COPD, let's do a spinal instead of a general. I'm not sure that doing a general in a patient who's got COPD, even if, you know, if it's moderate, is necessarily a bad thing. And I think we've all done tons of general anesthetics in patients with respiratory disease who haven't ended up in ICU and ventilators. But at the same time, and this is the thing, similarly, and this is the Association of Anesthesiologists' approach, is that they said spinal hematoma, when you look at the data, we talk about spinals, and the problem is neuroaxial anesthesia is often conflated, right? They'll talk about epidurals and spinals the same way, but epidurals, you know, you're putting much larger volumes in, it's a larger needle, you're putting a catheter, it stays in. The incidence of hematoma is much, much higher for an epidural versus a spinal, and that is partly what they base their recommendations on. You know, spinal hematoma is something like 1 in 700,000 versus 1 in 3,000 to 1 in 5,000 with epidurals, depending on the data set that you look at. So yes, so that is basically what they do, and in particularly if you're using a small gauge needle and it's atraumatic, I think that risk is we're perhaps overstating it. The problem that's always in our mind is if that 1 in 700,000 happened and we were put up in court, it might be hard to defend ourselves. But luckily, we do have this guideline document to now something to fall back on. But yeah, you know, these things I don't think there are any right answers, and I have to do what's
the patients that I'm really worried about are those with severe pulmonary hypertension and or right ventricular failure. I think those patients really tolerate general anesthesia very, very poorly. So if I'm, you know, even if they are anticoagulated sometimes or on antiplatelets, I have done spinal anesthesia in these situations in patients that have severe cor pulmonale or, you know, pulmonary hypertension and things like that. And I explain it very clearly to the patient beforehand, or to the family if the patient is not, you know, if they are out of it. And so I say, you know, I tell them we don't have an ideal anesthetic for your mother. We have 2 options, and they both have significant risks. The risks of A are these, the risks of B are these. I do think that when we put everything in the balance, I think the risk of doing a spinal anesthesia, the risk of bleeding and having a paralysis after that are probably lower, much lower in this particular case than the risk of a general anesthetic and the impact on the heart. But usually for me, those are the most, the most worrisome patients in my mind. And I have done spinals in situations like that, patients on Plavix and patients on direct oral anticoagulants that didn't quite fit the guideline. They were shorter period, but they had, normal renal function, and maybe they were off for 24 hours, something like that, on rivaroxaban or something like that. I have done that in the past, but very good documentation. I write, a half a page on the chart of my conversation. Yeah.
And then if you decide to go down that route, then clearly, again, what is within your control is making sure that the procedure is as straightforward as possible, right? So the fewest passes with that 25 gauge needle. I mean, we all know that how many times do we get blood back, a bloody CSF with a 25 gauge needle in the midline approach. And so you want to do things like ultrasound and find a good space and mark it, and so that you get it in a single pass, or one or two redirections. But if you start to struggle, the patient is going to be difficult or looks difficult, then you may want to have that plan B and know when to stop, because obviously if you're going to make multiple holes and cause a lot of bleeding, then that risk of hematoma, a significant hematoma, is obviously going to go up, right? I'm always amazed that but blood patches in that respect have always amazed me, right? Because we inject 20 mils of blood, 30 mils of blood without worrying about the epidural hematoma. So it's always been a little bit of a conundrum for me about the risk of a spinal hematoma with a spinal needle. Okay, I think we're running over a little bit of time, but if anybody needs to leave, please leave. The last thing we'll touch on very quickly is local anesthetic systemic toxicity. The article that I presented here is, am I sharing my screen? Is again from that anesthesia supplement, which is free to access. A couple of interesting points it does bring up is that a lot of times now we have to think beyond just our regional anesthetics, because local anesthetics are applied liberally in many situations. And certainly here at the Western, we do lots of awake intubations. It's quite easy to get carried away with your amount of lidocaine that you put into that into the airway as you're trying to numb the thing. And obviously now there's a huge vogue for peri-articular, whatever infiltration by the surgeons, and we need to be aware of that, particularly if we're combining it with other things, and along with that comes an increasing vogue for IV lidocaine infusions. And I've certainly had one episode where I was doing a rescue truncal block in PACU, and didn't really check the records and didn't see that she had been getting IV lidocaine during the case. And I did manage to give the patient a minor last reaction, neurologically only. But it's something to think about. But particularly you could have that too if you were running the IV lidocaine and the surgeons decide they're going to infiltrate as well. You just have to be cognizant of the total dose that people are getting, because obviously that's what is most important. And also that there are various patient factors that for any given dose will increase the risk that they will manifest as last. And I included this figure over here, which lists some of those factors. We know pregnant patients are a little bit more vulnerable. Obviously, if they have renal and liver disease that impairs metabolism and redistribution, that's a problem. So those are important things to also think about when you are considering how much local you're going to give. And then obviously the final thing is, very fortunately, we have lipid emulsion now, which is really a magic bullet when it comes to reversing a lot of the effects of LAS. And remember that I don't know how many of you have actually seen LAST, but I've seen it a few times. It is very rarely the classic symptoms. I say anytime anybody's had a significant dose of local anesthetic and they just start behaving weird, which is like neurological manifestations, it should always be in your differential diagnosis, because they can range from sort of agitation to feeling they can't breathe. Some people have visual changes. It's really, really very varied. And it's, if you can't find any good explanation for it very quickly, give them a test dose of intralipid is kind of my advice. And that's almost diagnostic, because if it is LAST, it disappears within 5 minutes of them getting that bolus dose. Anybody want to comment or share thoughts on LAST?
Hi, Ki-Jinn. So it's funny you had that last event, because I spoke to Guy Weinberg once about this, asking him, when is it safe for me to do a rescue block if somebody ran lidocaine intraoperatively? Because we had a colleague that came from Ottawa, and he was telling us that they do it very frequently, where they do tap blocks after lidocaine infusion. And Guy was obviously conservative, because he sees kind of the severe end of the stick with his reporting database. But I think he brought a good point that, the pharmacokinetics of the absorption and the lidocaine, you want to wait at least a few half-lives, right? So if a half-life is, let's say, 90 minutes to 2 hours, like one half-life is probably not enough. So he didn't have a number for me, and I obviously, it's hard. But he said, if you wait something like 6 hours, it's been like 3 half-lives, you should feel a lot more comfortable. But certainly, like, just one half-life is something that increases the risk. Obviously, it's dose dependent on how much you're putting in the rescue block and how much they ran. Like if you ran 1 milligram per kilo, 1.5 milligram per kilo, these are all things to consider. But I thought it was a thoughtful response, because using half-lives at least is something we can measure and like would be a feasible approach. And sometimes you still do need to do that rescue block at some point. So when is it safe to do that? That might be a useful approach.
Yeah, it's perhaps something that you need to factor in when you're thinking about using IV lidocaine at all, is how much you believe it's going to work for your patient, because it shuts out a lot of options. And if we ever see liposomal bupivacaine arrive, let me tell you that that will also shut out the option of rescue blocks, because you're not meant to give any other local anesthetic within 48 to 72 hours of a patient having had liposomal bupivacaine. So these are all things that are probably going to crop up on our radar.
Can I just add, so I saw LAST for a emergency C-section that we were topping up after the patient had had an epidural running for a long period of time. And so I've seen LAST a few times when I was at Sunnybrook, and it almost always was a patient becoming like just agitated. And I think they had gone past that point of like they were already toxic, and that agitation was always the first thing that was obvious. But this patient actually had some medical background. They were a dentist, and as we were topping up, because it was an emergency, they said to me, I have metallic taste in my mouth. And I said, oh, okay, you haven't brushed your teeth in a few days. I'm sure that's what it was. And then she told me she was a dentist. And I'm like, oh, okay. So we gave like intralipid immediately. And I think the point I also want to make is we then did the C-section using the epidural, because it doesn't actually just dissipate the block. It just soaks up the toxicity level that you're getting in the vascular system. But then we were able to do the epidural. I was like, don't use it anymore afterwards. And we got through the entire C-section. But I never regretted giving intralipid. Just have a low threshold to give it, and realize that it doesn't mean, like, especially in a situation like this, it doesn't mean that you can't use the block that's already there. It just means it's going to stop up the intravascular component that's causing your problem right now.
That's a really great story. Thank you for sharing, because you answered one of my questions that occurred as Josh was talking about it, which was, should I just do the block anyway if the patient's in a lot of pain and just have the intralipid ready to go, right? Rather than wait 6 hours and have the patient in pain.
Don't do the block, Jen. Don't do the
block. Pain never killed anybody.
True.
As our surgeons would say. Yeah. But Yeah, so thanks, Roger. That's a really good point, right? That the it's not an naloxone thing, right? You're not going to lose the analgesic effect of your local anesthetic. It's good to have confirmation of that firsthand. Anything else people want to bring up in the last couple of minutes? If not, okay.
Ki-Jinn, maybe mention,
Yes.
briefly our discussion with Rochelle about, outpatient local anesthetic administration.
Mhm.
Because, I do feel that it changes the goalpost a little bit. And I would definitely, something I would, let's say, for example, if I had a accidentally intravascular puncture during catheter placement, I would certainly abort the procedure and not send a patient home with a catheter. I wouldn't reinsert it. Whereas it's an inpatient, and I have more monitoring, I may actually kind of recite it and have better monitoring. So I have thought a lot about this topic because we've chatted about it, but I think it's like just wanting to hear your thoughts and the rest of the team.
So just for context, this is related to a discussion about outpatient adductor canal catheters, and one of our colleagues, Rochelle, who will bring up in Kitchener, has found that 0.2% ropivacaine, she has found in her experience that running at 8 mils per hour is far superior to 5 mils per hour. But what Josh is referring to is whether or not there is a material increase in the risk of blast because of the higher dose. I don't know.
Yeah, I don't know. In the past, a few years ago, we were sending patients relatively often with popliteal blocks and with brachial plexus blocks, infraclavicular catheters, and I was running them at 7 cc's per hour, so very close to what Rochelle's doing. And we may have done probably, it wasn't a huge volume thing. It was a total of about 100 patients altogether. And we never came, we were following these patients on the phone until the pump was empty, so 2-3 days. In those 100 patients, we never came across a case. But I like your point, Josh, of what happens if you have a vascular puncture, because that may change the situation a little bit, right?
I will say that I've never heard in the literature of just thinking about all the papers I've read that have dealt with outpatient catheters about last ever being expressed as a significant concern with outpatient catheters. It's always about the failure of the catheter, and I've never really seen last come up at the doses that we're talking about. And I think up to 8 mils an hour is reasonable. Of course, there are a couple of things to think about. We do have an older patient that, again, if you look at those risk factors about sensitivity, because remember, at the end of the day, whether you get last or not is not necessarily dependent on an absolute patient plasma concentration threshold, but whether that plasma concentration threshold actually affects their heart or the brain of that particular individual. So we are dealing with an older population. Should we be more careful there? And then if they're also injecting their local infiltration at the end of the case, obviously then they've got this depot of ropivacaine as well in the tissues. So certainly maybe for the next 12 to 24 hours, they have higher concentrations than if you were just running the infusion alone. So, it's one of those things where probably, looking at large numbers may give some reassurance. I think the vascular puncture and the vascular migration is a difficult one to quantify. I wonder if you did actually have a catheter that went intravascular, whether the 8 or 5 is going to make a difference. You might still get lost with 5. Difficult. There, guys. It's about how it's about where you peg your comfort threshold. How far do you want to push to get efficacy? Have you resolved that yet, Josh, in your head?
Yeah, I think we've had very good results with 5. So I feel like erring on the side of caution, at least with the initial trials, is probably the best approach. And then maybe doing an actual trial that compares the difference in efficacy. I asked Baxter, I approached him and asked him, have they ever had a death or a severe loss as an outpatient in Canada? And they told me no, for whatever that's worth. But I did review a paper for the US where they had 2 deaths from outpatient catheters. Now the denominator was like a few 100,000 patients, so it's still very rare. Right. But these are just things to consider.
Yeah.
So I think starting maybe with a more conservative approach, and then seeing how it goes from there might be safer, and probably will help me sleep at night at least.
It's all about perceived benefit versus risk, right? Everything's a trade-off. Just for context, Rochelle's early data suggested 50 something% opioid free with the 5 mils, and now she's 80 to 90% opioid free with the 8 mils. So for her, it's she feels it's worth the theoretical.
Agent, what concentration does she run at? Well,
they're all 0.2%. But she said there's such a noticeable difference for her at 8 mils per hour.
Even at 8 mils per hour at 0.2%, it's a small dose if you look at the whole day. And that is spread out over the whole day, so it's probably not that likely to cause.
Yeah, it's one of those things. It's gray. Okay, well, I'm gonna call it to a close. Thank you all so much. I hope you all enjoyed that as much as I did. I think it's always great to have a discussion and hear things. So look forward. I think we'll try to use this format quite a lot of rounds going forward, which we hope to have every month. And thanks again to our friends from Mount Sinai and elsewhere who have joined us. Wish everybody a good evening. Bye.